want today to welcome back Betsy Thompson from U.S. Health and Human Services, and along with Dr. Parag Agnihotri, who had been at Mercy and had been part of University Best Practices, and now is having to fly up to help us understand how he's improved Sharpry-Steele Medical Group. It's lovely to see such a big crowd today. I also want to welcome back Dr. Matt Wanacott from the Air Force, and he can tell us a little bit about that when we send the microphone around shortly. And I know that Betsy has an introduction that she would like to make to start us off. So you have a mic right there, Betsy, if you want to use that. Come on up here. Yeah, I can do it right here. Can you hear me? Is that on? It's a pleasure to be back with you. Some of you know me. I haven't been here for a number of months, but made it today. And I was really happy to bring with me, or not actually with me, to make sure that she came, the new Regional Chief Medical Officer for the Centers for Medicare and Medicaid Services, Dr. Ashby Wolf, who a bunch of you have met already. As you may recall, that I left that position not quite a year ago, so they were really lucky to get Ashby in there and for her to be here with you today. So that's all I wanted to say, and thanks for your all coming today and making time to be here with us. Thanks. So, Carla, are you going to start the microphone?
We have to.
Thank you.
Okay. Susan Ivey, I'm at UC Berkeley, the School of Public Health, a professor there teaching the Joint Medical Program and also a family medicine physician.
So Ashby Wolf, I'm the new Betsy. I'm also a family physician, and I've been at CMS for 4 weeks, so I'm looking very much to get to know each and every one of you and helping this important endeavor. Thanks.
Jessica Nunez de Ibarra from the California Department of Public Health, responsible for California Wellness Plan implementation.
I'm Nick Smith. I'm with the American Heart and American Stroke Association. I'm the regional director for ARCA with the guidelines programs in Northern Nevada and Northern California.
My name is Katie Weber. I'm with Baird Medical. I'm Senior Care Account Manager.
Hi, my name is Amanda. I'm currently an undergraduate student at UC Berkeley School.
Don Hufford, CMO, Western Health and Dandy.
I am Jim Cordes. I'm the Northern California Medical Director for United Healthcare.
Hi, Chris Wood. I'm the Administrator for the Dignity Health Cardiological Institute.
Hi, I'm Juliana. I'm with UC Davis in the Pharmacy Department.
Nancy England, Blue Shield, ACO Program Director.
Leonard Fry, LWF Home Care, San Jose, Sacramento.
Jerry Jeffy, California Chronic Care Coalition.
Hi, Jan Vandermeer, Ambulatory Care Management Director. I have embedded case managers in physicians' offices at 18s, and I work for Center Health, Sac Sierra region. It's now an operating unit, but never mind.
I'm Paul Small. I'm Medical Director for UC Davis's Patient Centered Medical Home, Transformation Work, and Care Coordination.
Hello, Bridget Levitch. I'm the Director of Health Management and Education at UC Davis.
Emerald Montgomery. I'm a Research Analyst at the Institute for Population Health Improvement at UC Davis.
Hi, I'm Mary Watanabe, Deputy Director for Health Policy and Stakeholder Relations at the Department of Managed Healthcare.
I'm Linda Blake, and I'm the Supervisor of Care Coordination at UC Davis.
Mike Saunders, UC Davis Health System.
Hi, Risa Vitaka. I'm with Safeway Corporate and at UCSF.
Deanne Blankenship, Director of Program Services, California Health Collaborative.
Jen Wergman. I'm Vice Chair of California Health Collaborative.
I'm Martha Gertie. I'm with HealthNet. I represent health education for Northern California and the Cardiovascular Health Initiative.
Warren Burns, UC Berkeley School of Public Health, and Grace Presbyterian Church in Sacramento.
I'm Stan. I'm with Safeway Corporate.
Roy Schutzheim, I'm with Calvin Health Center, I'm the chief medical officer. All right.
Hi there, Yvonne Rodriguez, Sacramento County Public Health.
Brandon Walker, Novo Nordisk.
David Matsumura, Nova Nordis.
Lisa Ashton, Jasmine Johnson, healthcare assistants.
I'm Joy Lummery, also Johnson & Johnson, Janssen Scientific Affairs.
Hi, Kylie Kane, Senior Program Officer here at the Sierra Health Foundation.
I'm Colonel Matt Wanacott. I'm the Deputy Commander of David Grant Medical Center. So it's the largest Air Force, fully Air Force hospital medical center in the United States. And it's just south of us. We have about 2,500 staff and we have about 40,000 enrollees. But if you open up to the VA, which is not the same as DOD, but we do see VA patients, then we have a population of about 500,000. So that makes it quite large. Glad to be here.
Hello, my name is Jim Ellsworth. I'm the Executive Director of Capital Health Network. Capital Health Network is the consortium of federally qualified health centers and community clinics serving the communities in the Sacramento region.
Mike Hoover, Medical Director for Administrator UC Davis, and also the Assistant Medical Director for the Primary Care Network.
Amanda Opusel, Manager for the UC Davis CAP program.
Maureen McKinnon, I'm with UC Davis.
Sherman Hamilton with UC Davis.
Mr. Roger Tiao, pharmacist with Health Physicians.
Janet Bates, Chronic Disease Control Branch in the California Department of Public Health, and I manage the California Stroke Registry.
Good afternoon, everyone. Desiree Backman, Chief Prevention Officer with the California Department of Healthcare Services.
Hello, Maureen Phil, Nurse Consultant with the California Department of Healthcare Service, and I work with the Medical Health and Care Plans.
Hi, Rachel Albert, the Department of Healthcare Services. Hi, Jennifer Berg, the Department of Healthcare Services.
Hi, Florence Nerby. I work with Blue Shield on their 6 of their ACOs in the Sacramento area. I'm the clinical program manager there.
Hi, I'm Sue Fuentes, and I'm with the University of San Francisco, and I'm active in the Sacramento branch.
Tina Jacinto, I'm with AbbVie in the Population Health Department.
Kristen Robinson, Chief of Chronic Conditions Management at Kaiser and Sacramento.
I have David Eichmann, Medical Director of Home Care.
Don Forrester, Medical Director, Switch Healthcare.
And Yvette Koppel, I'm the Director of Advanced Practice at California University. Is that everybody? Has everybody had a chance to introduce themselves? We want to thank our wonderful videographer, Bill Remack, and the California Chronic Care Coalition for their constant volunteerism in support of the Right Care Initiative, and thank Sierra Health Foundation for their amazing hosting of us every month with our Heart Healthy menu. Really appreciate that. Novo Nordisk, Boehringer Ingelheim, Johnson & Johnson, AbbVie, thank you so much for your ongoing support that makes this possible. The Health Services Advisory Group is generously offering continuing medical education and nursing education for all of you. We encourage you, you have on those yellow sheets the material you need to sign up for your continuing education. And we'd appreciate it if you would try to do that so that we have this continued support for this wonderful donation that the Health Services Advisory Group is enabling to support improved management and prevention of heart attack, strokes, and diabetic complications. And with that, I would like to ask Dr. Mary Firmison, who's the Chief Medical Officer of Health Services Advisory Group, and Dr. Susan Ivey from UC Berkeley and UCSF to come up and give us an update on their hypertension project that was at the request of the clinical community of Sacramento, prioritizing hypertension and the education of the highest risk patients and their families. So these wonderful physician leaders will talk about some really nice implementation progress.
Okay, I guess I have to start. Can you hear me? Okay. So we, many months ago, decided that we will, amongst all of the goals of Million Hearts, that we will start with hypertension. And so the leaders in this community here have decided that we want to do something about hypertension, starting with the JNCA guidelines and implementing it and so forth. One of our co-chairs, Dr. Ertl, who happens to be on vacation today, had developed a survey for his physicians in his Mercy Medical Group to see, assess their knowledge base for treatment of hypertension and assess their barriers in controlling hypertension. So this survey was implemented by him, and he presented his results way back, I think in January, and shared it with this group. The results were a little maybe not so surprising, but surprising too. Most of the physicians said they know about the JNCA guidelines, but when the specific questions were asked about treatment of a certain group of patients and what the starting drug should be, the answers were all over the place. So so he had decided to implement certain interventions in his group because of that. Now, when this was presented here, other medical groups would like to implement the same survey. And I happened to have the occasion of talking with the medical director of CAPG. CAPG is the California Association of Physicians Group, and I presented the survey to her clinical quality committee. And there are many of the leaders of the medical groups who are participating, and they all are interested in implementing the same survey. So now, Dr. Ertl has graciously agreed to implement the survey more broadly. And so at this point in time, what we're doing is, with yet another partner, which is here actually in LA, we're partnering with the USC School of Pharmacy. And the Steve Chen, the professor of pharmacy, had graciously stepped up and said that he would have his survey experts look at the survey tool, the questionnaire, to validate it and make sure that it is cognitively tested and so on, so that we will all get the same interpretation of the survey before implementation. So that's where it is at. And hopefully we'll be implementing it more broadly with all of the medical groups here, not only here in California, but also in other states, because we are involved with other states as well. And with regards to that and JNCA guidelines, we have also decided to develop a treatment algorithm, and with that I'll turn over to Dr. Ivy.
Let's see if it opens. Okay, so this is what we talked about last time for any of you guys that missed it, that we've created now sort of a pocket-sized card that will have the JNCA algorithm. It also has some updated references on the bottom, and this has now come out hopefully to all of you as a PDF document, but we've also created it so that it can be printed onto the back and the front of a card, like the one we saw from the Gunderson Health Plan folks. And that has now come to you hopefully as a PDF document. If for some reason your group or you personally didn't receive that, then please respond back to us and let us know. We'll make sure that you get a copy of that. As well, we're looking at pricing for printing costs, and I don't have those yet, but hopefully we'll come up with something that makes it a manageable cost to do limited printing. And the other thing I'd like from you guys on that is if you really would want to have printed versions to get out to your physicians, if you could please drop either me personally or Hattie a note and just let us know that you're really interested in print versus electronic. And then Dr. Firmason on HSAC's part will be looking into how to take this algorithm and facilitate embedding that into people's electronic health records to be used as a decision-making tool. So, Mary, is there anything else you want to say on that?
While she makes it back to the podium, I'll just say that Dr. Revelo and Dr. Ertl could not be with us today. Dr. Revelo is presenting to our congressional caucus in Washington, D.C., and Dr. Ertl is in Germany. But Dr. Revelo did send out to the physician leaders an electronic copy of that JNCH algorithm. This is not an algorithm that was created by the Right Care Initiative. It's simply being distributed, and Dr. Mary Vermison, many other clinicians in the area, Dr. Ivy, made sure that it was absolutely perfect. Amanda Liu did the graphics for it, and now the California Association of Physician Groups is actually going to produce it and distribute it at their 4,000-person conference in Southern California. So hooray to Dr. Arevalo for the idea to create a simple pocket card like what we had presented by Gunderson Health System maybe last month or the month before that. Just a very practical tool that's always with the clinical team. Surprisingly, every little sample copy that we created and brought to this group or Los Angeles, the physicians ate up like candy, and there were none left for me. So really appreciate our physician leaders for making this available for the region.
So just to say a few words about, aside from making it into a pocket guide, here with us, with our HIT team in our organization who are implementing or helping physicians implement EHR and use their EHR for care management, we're hoping to be able to work with the vendors to incorporate the guidelines into the as a clinical decision support tool in their EHR. And so that's a work in progress. We'll keep you informed on the progress as we go along.
So hopefully we'll just kind of leave this on as sort of a standing agenda item, and Mary and I will continue to update her, Dr. Revelo, when he's back as we get new information. And I'm not able to turn it off. So.
Are there any questions for Susan or Mary before we move on? We are very, very fortunate today to have Dr. Neil Kohatsu, the head of the Medi-Cal clinical program. He's the chief medical officer for Medi-Cal. And he is also doing a wonderful hypertension project. So he's been my great collaborator since 2008 when we launched this publicly, and we're so thrilled he's back in the room with us today to help us co-facilitate.
Patty, thanks so much. And really on behalf of the more than 12 million Medi-Cal members we serve, as you noted, hypertension and more broadly cardiovascular disease and diabetes prevention and control are very high priorities. My colleague Desiree Backman, in fact, as you noted, who's our chief prevention officer, leads efforts in our Million Hearts Initiative. We have colleagues from managed care and many other divisions. Pharmacy, won't cover them all. But we as a department are committed for those more than 12 million Californians that we serve to advancing with the expertise around this field, cardiovascular disease and diabetes prevention and control. So it gives me, it's my great pleasure and honor to introduce Dr. Parag Agnihotri, who has expertise both in the Sacramento area, as was alluded to, but what he's going to talk to us today, this afternoon, is about his experience at Sharp Stelia as a really medical leader and innovator in prevention and in cardiovascular disease prevention and control. So without further ado.
Our Platinum Award winner, Parag Agnihotri. lovable, wonderful teacher and leader, and many of you know him. But I'll just say that the way to get the Platinum Award is to hit every single target for cardiovascular disease and diabetes. There are only 2 groups in California that have done it so far, and Dr. Agnihotri is one of them.
Well, it's the Sharp-Stelli Medical Group. I just happened to work here. So I think, first of all, good afternoon. Thank you for the kind introduction, Hattie. It's very exciting to be back in Sacramento, to be able to say hello to a lot of my friends and colleagues. I've had the pleasure of working with you for many years. My wife still wishes that she would be back in Folsom sometimes, but I think we're happy and well settled in San Diego now. So the second thing is, when you get re-invited, over the years, I've just learned to say yes to whatever Hattie says. So I think you might have heard me speak a little bit before, but I think my assistant will just go, we'll just cancel the board meeting or anything, just go and go speak in Sacramento. So I'm here, glad to be here. This is, Sharp-Stelli's journey towards improving the health of hypertension, cardiovascular, and diabetic population. Dr. Firmazin gave me the guidance, we just need boots on the ground perspective of what's exactly happening at the group level, how people are at the front line really addressing this. So this is not a high overview presentation, so I hope you can take that. At the end of this session, I think we'll have Q&A session. And I have purchased 5 more minutes from Warren, so you can have a good Q&A later on. So the objectives are, how do we really promote team-based care? How do we really look at addressing practice variation? And remote patient monitoring to promote patient engagement. And again, Q&A later on. I think that's sometimes the biggest value. In general, I think we're trying to really address how can we have integration of process, people, and technology. How all these 3 involved, and how can we really have this as part of the 3-part aim. For Sharp-Stelli also, we want to have better care, better health, lower cost, the same as CMS and CMMI, the patient, person, or a consumer at the center of this. So why use a team to really manage population health? Because we are moving away from the fee-for-service model. We are being now part of the value-based care, accountable care, where we are going to be held accountable for panel management. We have to not only improve quality, but we also have to demonstrate a reduction in total cost of care. And now, this is a well-published paper that delivering safe care is virtually impossible without a team and system. This was a very good paper by Dr. Bodenheimer. Many of you must have seen this. For a primary care physician today, you almost need 21 hours a day to deliver all the things which we expect them to deliver, which is virtually impossible. That's why we need a team and a system. So what are we trying to achieve? Well, when you look at this group of people, or whether it be in San Diego University of Best Practices, what we're trying to do is how can we get blood pressure control on a population health level from 75% to 80%? How can we get the diabetes measure score to be above 50%? And how do we really reduce burden of cardiovascular disease? The first 2 are more process measures, but the last measure is more outcome-based measure. And that's what we would like to do here. I'm just checking. You guys can hear me in the back, right? Because I know the audio sometimes goes. So how do we really reduce the burden of cardiovascular disease? That's what we are trying to, that's the end goal. That's what we are trying to do. And how can we look at a large multi-specialty medical group? And I think, we have almost 250,000 assigned patients, 1.4 million visits, and all this staff and all these clinic locations spread throughout San Diego County. And I'm sure that many of you in this room also have similar group profile as what we have in San Diego right now. So these are some of the important components I would like to touch base about. These are the 7 domains. We can quickly give a quick overview of exactly how the group is trying to address this. And I think in each of this slide, the area which, the domain I'm trying to highlight, it will be highlighted in red, it will be in red on the bottom. But eventually, I think we hope that all of these systems align well so that we can demonstrate the effectiveness of our intervention. So first of all, I think aligning stakeholders is very important. And I think we do have some Q&A, just to keep everyone's attention and not have a post-prandial dose. But I think here are some questions for the group, so just take your time and you could answer. So when you look at, what's the average prevalence of diabetes in US, it's almost, I think most of the people said 30%. That's possible. Certain parts of the country. But I think, its average prevalence of diabetes is around 8%. 8% is B is the correct answer, 8% of diabetes. Okay, let's go with the next question. What's the total annual cost of healthcare for an individual with diabetes? And the answer is correct. I think 14,000. 14,000 is the average annual cost of care for a patient with diabetes. So when you look at, for us in San Diego right now, 8% of San Diegans have diabetes, 28% have hypertension. At Sharp-Ray-Steele, in our data mart, we have 19,000 diabetics, people who have been diagnosed with diabetes. Every year the number continues to grow. So 19,000 diabetic, and this is the cost. This is based on a paper from ADA, which shows that almost $13,700 is spent per year at the care of patients with diabetes, of which almost 7,900 is directly attributed to diabetes. And the cost mainly comes from things like the inpatient care, some of the medications, and the rest of this. So we can do a simple math here that if we today are accountable for the cost of this patient population, if we are at risk, then it's almost going for 19,000 members, and if these patients were uncontrolled and having complications, we would be almost spending $250 million as a group on taking care of this diabetes population. So even if we can make a small impact, even a 5% impact, will have enough cost saving for us to demonstrate the ROI and all the things, and we can reduce the burden of complications of this illness. So I think, and on the top of this now, we are held accountable through various quality programs. Right now, Sharp-Ray-Steele almost reports 100 quality measures per year. We are part of every single program, whether it be meaningful use or CMS or ACO, shared saving, there are incentives or penalties or gate for shared saving. So whatever way we look at it, we are accountable for so many of these metrics and so many of our process measures right now, which includes diabetes and hypertension. So it makes perfect sense for us to have all these population health measures are on our Sharp-Ray-Steele's balanced scorecard. This way, even the CEO of the healthcare system today knows that we have an annual target for diabetes perfect care, which is a bundle measure, and he and the leadership team set annual goals for us to really meet those targets. So now we have everyone aligned, the board, the physicians, the staff, all the people, their merit-based incentive, their payment, even their incentives are aligned to the APC score. So this is great, I think this, having that great attention really helps, right? But there are also unintended consequences where, I have sometimes now people, if our scores go down by even 1%, I get called into the room and say, okay, Parag, what are you doing? How can we help improve the performance? So I think there are good and bad. I'll take the whole thing where people are paying more attention to this rather than my hand expands for that. But I think, I think we really appreciate, how the leadership has embraced population health measures on their report card. So that's aligning stakeholders. So now you have decided, now you have said, look, great, we are going to now be an NCQA certified program, disease management program, because this is so important, this is something we need to do. So there are two ways you can now go move forward. You know, one is this clip. You know, I'm going to share this clip with you. It's a 3-minute clip, and it should be clicking.
And if you like, we can also send that out, Carla can send that out in the, along with the slides, so people can watch it on their own computers later and share it with their staffs.
So there are two ways.
Hello, it's so nice to interact with you today. My name is Nurse Verizielas, and I'd like to help you become engaged in the personalized ongoing management of your diabetes in the context of your medical home. Would you like to become engaged and ongoing in managing in home while I get a monthly fee on your behalf?
I don't have diabetes. My doctor told me I have a slight case of sugar. I would like to stop taking so many pills.
Thank you for sharing in that decision-making with me. Let's talk about your blood sugar control. Are you following a diet and exercising regularly?
Well, while I prefer to eat an entire roast chicken for dinner, I exercise afterwards by putting on ankle weights just before I climb into bed. That way, when I roll over, I burn some calories.
Well, now that we discussed diet and exercise, I can cross that goal off of my plan of care documentation. Let's talk about your A1C.
What is an A1C?
I will now instruct you about your A1C. That is a test of overall blood glucose control. Persons who are fully engaged and compliant with their diabetes management will have an A1C that is less than 7%.
When my blood sugar is under tight control, I feel dizzy, get gas, tired, experience hair loss, and I get spells of hypoglycemia and pass out and twitch and drool.
I'm glad we had a chance to engage on the A1C and that you have been educated. Now your managed care plan will get HEDIS credit. We will get NCQA accreditation. Now I would like to talk about your medications.
Ever since I started taking so many pills, both of my eyes hurt whenever I go to the bathroom. I want to stop taking so many medicines.
I recommend that you take the big white pill twice a day instead of once a day. Takes 4 of the small yellow ones every 4 hours and take shots of insulin twice a day.
Are you a doctor?
I am just like a doctor because I am working at the top of my license using a computerized decision tree with evidence-based patient-centered protocols.
I see.
No, it is your A1C. And I see we are out of time. I will email or fax your doctor about our shared decision-making and care plan. How about we make an appointment to engage again in 8 weeks?
My doctor does not use email and his fax machine is burned out from overuse from nurses like you. And by the time 8 weeks is over, I will have forgotten everything you told me.
I am glad we have shared in the decision-making for 8 weeks. I will see you then. It was very nice engaging with you on helping you with your diabetes.
I don't have diabetes. I have a slight case of sugar.
So I think we can see, obviously, this is not the way we would like to really engage our
Hello,
patients.
attributed ACO and Marlene. I have good news for you.